series that's put on by the Heart Institute of the Caribbean. My name is Michael Anthony Cuff. I'll be your moderator. It's nice to be back with you once again. This week, we're going to be looking at some myth busting around the question of COVID-19. But before we do, let me just give you a brief background about the Heart Institute of the Caribbean. As you would know by now, they're the premier institute when it comes to heart care, and they've been around for the last 15 years. Recently, they've opened the HIC Heart Hospital, which has been doing some amazing work in that area of cardiac care. And of course, they're extremely proud of what's been, the work that's been taking place since they've opened their doors. This week, we're going to be, as I said, looking at myth busting. But before I introduce my panelists, I'd just like to, brief my participants. Of course, as always, this program is really about you. So therefore, whenever if you have a question, and I'm sure you have lots of them, please feel free to just raise your hand and we will acknowledge your presence. When we do that, then you ask your question and our doctors will be happy to give you their answers. You've got questions, you've got answers, all right? Okay, so just to tell you who our guests are, you've met them before, but in case you've joined us for the very first time, I have the pleasure of welcoming back the chairman, and he's also the founder of the HIC. I'm talking about Dr. Ernest Madu. He is an eminent cardiologist, and with him is another one of the cardiologists at the HIC. I'm talking about Dr. Paul Edwards. He was here with us a couple of weeks ago, and of course, he's another of the very skilled cardiologists at the HIC. They'll be here to take your questions. And as a matter of fact, let me just bring them into our discussion right now. Doctors, welcome. Nice to have you back with us again.
Yes, good to be back.
Yeah.
Nice to be back. Thanks.
And again, it's always good to know that you're looking healthy and well, because these days we can't take anything for granted. So it's really good that, because you guys are on the front line. Eh? So nice to have you back with us. Very healthy and well. Okay. One of my, I won't say which of the cardiologists it was at HIC. And I said, Doc, how are you? And I said, no, that's my question. I'm supposed to ask you that. Okay, so let's get right to it. You both co-authored an article which appeared in the Observer, last Sunday's Observer, and you were speaking to myths around COVID-19, the coronavirus myths, right? And it's interesting because you would think by now that persons would have been long past that, but the answer is no. Okay. You also addressed a number of very interesting things in the questions in the article, and I would like us to start by looking at some of those, if you don't mind. For example, the very first question I came across here was one that has to do with, every time I think of this question, I blush. Drinking bleach was one of the questions that we had. It keeps coming up. Is this a quest? Is this something that someone should engage in or not?
No, I think that I think some confusion may have occurred because of statements coming out of the US, but we need to clearly state that drinking bleach won't prevent coronavirus, and drinking bleach could damage your gastrointestinal tract and could kill you. Mm-hmm. So that's the simplest thing to say. But not only that, one has to be careful as well with washing the outside of your body or your hands with bleach, because bleach will kill things. And in addition to killing things, it can kill your own cells in your body. so that it's okay to use diluted bleach to clean off surfaces and stuff like that. But really, 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 we should avoid consuming bleach, getting bleach undiluted onto our skin, et cetera, et cetera, et cetera. Really, really dangerous.
Okay, so, and I hope that's the last time we'll have to address that. The second question is this. Is the coronavirus, is it a disease of old people only? Dr. Madu, you want to take that one?
Sure. The short answer to the question is no. It's not, right? All age groups are susceptible to coronavirus infection. And by the way, let's also make clear, we're talking about this particular virus is a novel coronavirus, SARS-CoV-2, but coronaviruses have been known, for hundreds of years. So children get a lot of coronavirus infections, and that's, known. But this SARS-CoV-2, which is the causative virus for COVID-19, it's particularly virulent. All age groups are susceptible, but the older populations, as well as those with underlying comorbidities or chronic medical illnesses, tend to be more susceptible and tend to have more complicated course if they get infected. Children, from the data available, tend to do better. It doesn't mean they don't get infected. In fact, children tend to probably be more asymptomatic carriers or to have mild or moderate illness that blows away. But even if you're a child or a younger person who is not as vulnerable to more complicated cause, you can put your relatives who are older or your relatives with comorbid conditions, you can put them at risk. And so that is why, we're appealing to everyone to take precautions to avoid the illness.
Could you explain the term comorbid for us?
Yeah, comorbidity is a term we use to describe chronic coexisting medical conditions, right? And so if someone,
for example,
has, and many of these things, comorbidity could be infectious or non-infectious illness, could be a comorbidity. But in this term, it often implies to the non-communicable lifestyle diseases and habits, high blood pressure, diabetes, heart disease, cancer, smoking, asthma, all these could be classified under the general term of comorbidity.
So, for example, if one has a heart condition, what would explain how the term comorbidity would work there? How would that work? One already has a heart condition, okay, that is known, all right? Or let me put the question another way. The coronavirus, if you contract the coronavirus and you have a heart condition, where is the comorbidity in that?
Well, the heart condition itself is the comorbidity, right? And so the significance of that is from the data that's available to us. We know that individuals with heart disease or other comorbidities like hypertension and diabetes, they're more susceptible to catching the coronavirus, the SARS-CoV-2 infection, right? But more importantly, their mortality, if they catch the disease, they're the ones that are more likely to have a serious complication. They're the ones that are more likely to die from the illness. So if we look at the case fatality ratios, we call it, or mortality, from COVID-19 across the world, reporting, we see that the death rates increase as we move from age groups. So 0 to 19 have very low fatality ratio. You go from 20 to 30, it's slow. 31 to 40 is higher. And then it keeps going on for every 10 years you add. So if you look at what happened in Italy, for example, those patients that were 80 years and more had a 22% mortality, right? But the overall mortality in Italy is about 7%. Then if you take all comers, like what we're seeing in the United States now, the mortality rates range anywhere from 3 to 4%. In China, we had about 2 to 3% based on what was reported. It could be higher than that. Now, but generally, the mortality rate across most countries reporting has, of all comers, been generally under 5%. Some in South Korea at one point was 0.5%. However, if you take the same all comers and look at patients with heart disease, the mortality rate is 10.5%. That is multiples of the overall mortality rate. If you look at those with hypertension or diabetes, it's between 6 and 7%. And then you look at cancer, it's about 5 to 6%. So what it tells is that if you have any of these underlying conditions, that's the best way to look at comorbidity, is underlying medical condition, right? If you have an underlying medical condition, then your risk is significantly worse than that of the general population if you catch the COVID-19. And now this is generally speaking, but individuals perform individually.
In the Caribbean, if you have a cold and you run into 20 different persons, they will give you 20 different home remedies. We have a home remedy for everything here in the Caribbean, as you know. Okay. When it comes to COVID-19, are there any home remedies or herbal remedies that we can take to prevent this thing?
No, I mean, the simple answer to that question is no. And it can be quite difficult for patients to, or people to understand that right now, we have one medication that seems to make a bit of a difference, you know what I mean? And in that kind of situation where people feel as if, there's not much that can be done to either prevent or treat it, then you go search for something else. I think what we can tell people is that the best thing to do is to try and stay healthy, right? So make sure you're eating correctly, fruits and vegetables, exercising. You keep your body healthy, you'll have a healthy immune system. What I tell my patients is that, most things that they will take won't hurt. So if somebody says to me, boy, I like to take garlic, I want to take vitamin C, I say, fine. But the thing you have to remember is that that does not take the place of making sure you're staying at home, making sure that when you go out, you're staying away from sick people, you're staying 2 meters away from everybody, you're wearing a mask. Do the things that we know will reduce the spread of the disease, you know what I mean? We don't have any evidence right now that any of these herbal or home remedies will help, right?
But I believe what I hear you saying, Paul, is that it can't hurt either.
Oh, I'm
it
sorry.
may not help, but it may not. You're saying that if you take these home remedies,
yes,
it won't necessarily hurt.
No, I mean, in other words, if somebody tells me that they like ginger or garlic or, they drink their Cersei tea, I mean, in other words, those won't hurt. And the important thing to tell people is that doing these things does not take the place of wearing your mask, does not take the place of make sure you're staying at home, does not take the place of keeping 2 meters away from people, So that the best way I put it is it most likely won't hurt you, you know what I mean? But, it certainly will not help.
Okay. This is, I've heard persons say, and I don't know that this was addressed in the article that you co-authored with Dr. Madhu, but I've heard persons say that, it doesn't have to be 14 days, and the quarantine period could be shorter. Now, why is 14 days just an arbitrary number that is used, or what is the thinking behind this? Why not quarantine for a week?
It's a
4 days.
question. but it mostly comes from what we call the epidemiology, or when the disease started in China and where they have the most experience, what they found is that if you can say with some degree of certainty when somebody was exposed and likely to have contracted the virus, right? What they tended to find was that people started to get symptoms at about day 4, day 5, all right? And if you ask the question, well, how long does it take for somebody to get symptoms? That question appears to be, it seems to be up to 2 weeks. You know what I mean? And that's the rationale for that 14 days. You know what I mean? Now it's not rock hard science. You know what I mean? And it's kind of the best compromise that we have in terms of saying that most people that tend to get symptoms after infection seem to get those symptoms within the first 14 days. Some people have argued that you might be a bit longer, and I know of a couple of cases where people have had quarantine for 21 days. But that's a compromise. That it seems that most people that get symptoms seem to get it within that 2 week window.
Yeah, why would that person who went to 21 days? Why would that be? Is that an extended?
Well, again, it's a little bit complicated because you're assuming that you know exactly when the person got it. In other words, let's suppose that you said, this man met this man and he caught it then. But let's suppose he didn't. Let's suppose that 5 days went by and he caught it from somebody else. So your time frame is not the correct time frame, Or it may be that there may be some people who are outliers. In other words, everything we do in medicine is a bit of an average, So that 14 days is a kind of a safety compromise, and it's kind of where we have the most evidence. That's the best way I can put it, I think.
Yeah, Dr. Madu.
Yeah.
Just to kind of follow up on this question, when a patient is tested,
mm-hmm.
if it turns out to be negative, obviously it means that the virus is not present in the body. Okay. But what happens if the day after or so they've contracted it? Because where I'm going with this question is, so how often should you be tested? If I were to, let's say I was tested today and I'm fine. Okay. How do I know that the next day, a week after, I won't contract the virus? So the question now is, how often should I be tested?
Okay, so we first, to address that question, we have to understand what is the reason for the testing. Why are we testing, right? Remember, this is a public health, crisis. It's a public health issue. So the testing, when we talk about testing and contact tracing and quarantine and all those, we're thinking about population health. We're talking about public health, how to protect the rest of the public. The testing, for the most part, unless somebody is known to be exposed and presenting with symptoms suggestive of the disease, and then you're testing in order to direct treatment or care. In the absence of that, when you're testing the population, you're actually trying to determine the exposure of the general population to the coronavirus. So it's not a question of testing and retesting and retesting. There is no purpose of that. In New York, for example, a recent sampling of coronavirus antibodies suggests that possibly about 20% of the population may have been exposed. So a lot of people may have been infected without knowing it, understanding that about 80% of people that get infected may have only mild or moderate symptoms and may not even come to the attention of healthcare providers to be tested. So there is no recommendation for multiple testing of individuals because it achieves no purpose.
So are you saying then that if you don't believe that you have been exposed, then there's no real need for testing?
No, there is no reason to go get tested if you don't believe that you have been exposed to somebody with an active infection, or, because first of all, we don't really know. Because remember, about 20% of individuals could be asymptomatic, right? So we think we've been exposed when we have been in the presence of somebody who is coughing and having fever and so on. But you could be in the presence of somebody who has no symptoms. And you're still exposed. So it is not strategically, operationally possible to test your test samples in the population to get idea of disease penetrance in the population, because you want to make public health decisions.
Okay.
But you can't test each individual in the community.
Can you explain for us how what's the thinking behind contact tracing? How does that work?
So it really, contact tracing is done at different stages of what we call an epidemic. So in a perfect world, right, you would have started very, very early, right? And you would have started when you only have a few people in your population, right? So let's suppose that a man came on a flight from New York and landed in Kingston, and you know that that man has disease. In that scenario, you can say, all right, well, who else was on the plane? Who lives at home with the man? Who did the man go and see when he came home? What party did he go to? What supermarket did he go to? And what you try and do is you try and trace everybody that man had contact with in an attempt to find those people. And if they have symptoms, you isolate them. So contact tracing is a way to try and prevent the spread of an epidemic very, very early. When you get to the stage where the epidemic is spreading throughout the community, where you have a surge of cases, where you're having people come out of the woods and you don't know where they got it from, then in that context, contact tracing is a lot less useful, because the virus is actually spreading from person to person within the community. So contact tracing is just simply a way of finding somebody with the disease, finding everybody they're in contact with, and getting to those people, interviewing them, testing if necessary, in an attempt to try and limit the spread, that kind of a thing.
This question came out of the article that you wrote. Can antibiotics prevent or treat COVID-19 infections?
So no. So when we say antibiotics, we are talking about a class of medication that is really used to treat bacteria, right? So COVID-19 is actually a virus, so that antibiotics in general don't treat viruses. Now, there is one antibiotic that has been talked about in terms of treating COVID infections, and that's azithromycin. But it's important to realize that it is not actually working as an antibiotic. What it's actually doing is it's changing the way the cell works and making it less likely for the virus to survive in the cell. But antibiotics don't kill viruses, so to speak. What we do have is what we call antivirals, which are drugs that basically work on the mechanism of either replication of a virus or preventing virus entry into cells, that kind of a thing. And one of those drugs, has basically been shown to kind of decrease the length of time that somebody has symptoms of COVID infection. So antiviral drugs, certainly can work, and we have evidence for one drug so far. But antibiotics, your amoxicillin, your ampicillin, your chloroquine, forget that. Your Bactrim, etc., will not either prevent or treat COVID infections.
Dr. Madhu,
Mm-hmm.
recently there was a story making the rounds in the news that Britain is very close to what might be a potential vaccine. Can you share any information you have on that for us?
Well, it's of course, there's a lot of interest in vaccines because vaccines are known to be effective in preventing some of these illnesses. But right now, there are so many candidate vaccines, we call them candidate vaccines, which means different types of vaccines in development. It usually takes anywhere from 12 months to 30 months to develop a vaccine. Do field testing on the vaccine, because you're going to do different levels of trials. We have we do phase 1, phase 2, phase 3 clinical trials to show efficacy of first you have to show that the vaccine is safe, and then you have to show that it works, and then you have to show that it can't work in a large population, to prevent illness. It's not only in Britain, different countries have different candidate vaccines. There is a vaccine trial going on in the United States, right now, but I caution everyone that we're very, very far away from actually developing a vaccine for the general population.
Okay. Can someone catch COVID-19 from their pet?
There is no data to suggest that pets are transmission sources for COVID-19. There have been a few reported identification of COVID-19 exposure with pets. That to say, there's evidence that this pet has had the COVID-19 virus, but there has been no report of pets transmitting COVID-19 to humans.
Just before we get to our next question, I'd just like to ask our participants, just to remind them actually, that if you have questions, we have answers. And now would be a very good time for you to send your questions to us, all right? So this program is about you, and so therefore we welcome your questions. And if you have a question just about now, please, let us know. We'd love to hear from you. There's a question here. Should I use ultraviolet or UV light on my body to kill the COVID-19 virus?
No, the answer to that question is no. Ultraviolet light, actually has been used to actually kill bacteria, viruses, fungi. And in fact, in simple day-to-day life, I don't know if in Jamaica it's very popular, but you do have these little boxes where when you have babies and the babies have bottles and the top of the bottle falls to the ground, you can put the bottle top in the little box to sterilize it. And most commonly that's using UV light. Ultraviolet light basically will destroy DNA of pretty much anything. The difficulty though is that when ultraviolet light is exposed to the skin or to the eyes, it can cause trouble. So that you can actually get sunburned, by fairly brief exposure to ultraviolet light. If you get exposed if your eyes get exposed, you can get inflammation in the eye and loss of vision. And over the long term, you can certainly get cataracts. Over the long term, there's also risk of things like cancer and stuff like that. So that we use UV light to sterilize things, not people, you know what I mean? And when you are sterilizing something, you have to be very, very sure that whatever you're using, you're not exposed to the UV light. So I know in the United States and in Asia, they have these little boxes, you know what I mean? Where you can put your cell phone in or your gloves, you know what I mean? Or, keys that you might be worried about, and close the box and give it some UV radiation. But it's really not something that you should expose your skin or your eyes to, because certainly you can get into trouble that way.
We talked earlier about the overuse of things like bleach on your hands, eh? And I look forward to the day when there's this gadget where you can just stick your hand under it, and it will tell you if the virus is or any virus is present on your hands. You know what I mean?
But to be frank, your hand is covered with bacteria and viruses. They're
not
bad ones. You know what I mean? They're all there.
Okay, so COVID, whatever it is, might be just mixed in. So either way,
mixed
make a
in.
difference. Okay, I got you. The other question, which I really think should follow on the heels of bleach and consuming bleach, is alcohol, because alcohol is used as a disinfectant at some time, and there is a question that can alcohol, if you drink alcohol, will that prevent COVID-19? Yeah. Will it kill the bacteria?
So certainly alcohol at a high enough concentration, and that's actually important to remember that, regular drinking alcohol, what I mean? So if you take your whites or your scotch and stuff and clean with that does not actually have a alcohol concentration that's high enough. You really need 60 to 7% alcohol, to actually be effective in killing coronavirus. And that works well for your hands, and certainly drinking alcohol does not help. The way the virus gets into the body is it gets into the mucous membranes lining the nose, the eyes, the back of the throat, that kind of thing. And drinking alcohol at a concentration that is in a normal alcoholic drink, will not help you. And drinking alcohol in too high a concentration can cause trouble, what I mean? That kind of a thing.
Can you explain for us, Dr. Madhu, when the term, if someone has a hole in the heart, what exactly does that mean?
Okay, it's a general, it's a layman's term, implying that there is a communication between the left side of the heart and the right side of the heart. That's when we say there is a hole in the heart. That's kind of like in a very broad way of looking at it. It's, to understand it better, you have to understand the structure of the heart itself. And I'm not gonna go into complex anatomy or anything like that, but I'm just gonna keep it simple. To say the heart as we know it has 4 chambers, right? 2 chambers on the left, 2 chambers on the right. And those 2 chambers are on top and 2 chambers below. So you have a septum, which is a partition dividing the left side from the right side. So the partition cuts across from the upper chamber to the lower chamber. So if there is any opening leading to communication through that partition, that could meet what is called hole in the heart. So let's take the most common hole in the heart reference we have is referring to the communication between the 2 chambers in the upper section of the heart itself. That, the most common is what we call a patent foraminal valley, or PFO, and that PFO could be an incidental finding in 1 out of 5 people, right? And for most people, it's just incidental finding. Now, if you have a hole that is large enough to become significant in a clinical way, that oftentimes will be what we call a defect. If it's in the upper chamber, it's called an atrial septal defect. And there are several types of those. That makes blood move from the upper chamber on the left, where the pressure is higher, to the chamber on the right, where the pressure is less. That needs to be corrected. It's often congenital. If we fail to correct it, it will get to a point where the pressure on the right exceeds the pressure on the left, and then the blood starts going back from right to left. The significance of that being that the blood on the right is often the blood that has not gone through the lungs to get oxygen. So we're now sending what we call deoxygenated blood from the right to the left, and it doesn't have enough oxygen content to run the affairs of the body. And that is a problem right there. Then we also have holes that communicate in the lower chamber. Oftentimes the lower chamber, the holes connecting the ventricles, we call them, can exist. Oftentimes they could be traumatic, or they could happen after a heart attack, and somebody develops a hole in there. That's also a hole in the heart.
If one was born with a hole in the heart, how would they know?
Well, that's, you start by, that's why you need to have a good clinician, right? There are certain, things that, you can begin with a physical examination where somebody might hear a murmur. Most people hear, they're told they have a heart murmur. You hear a sound, and there are different types of sounds that we can hear that can give us an idea what that might be. And if we hear a sound that suggests something like that, fortunately, we're living in a century where there's enough technology to find out. An echocardiogram is a simple ultrasound examination of the heart in good hands, and I emphasize in good hands. It's very easy to get an echo machine, but it's not always that easy to be good at either doing it or interpreting it. In good hands, it's very easy to make that determination.
So in good hands, would that necessarily mean a GP would be able to make a diagnosis, or would you have to go to a cardiologist in order to
well,
to get
again,
a good
again, I
diagnosis?
caution, they unfortunately, cardiology is a big discipline, requires a lot of training, right? And so
Let me see if sorry, we lost you there for a while, Dr. Madhu.
okay, no, I say everything depends on the skills and qualification of the person who is making the diagnosis. And in a well-trained cardiologist, that is not a difficult diagnosis to make.
Okay. Dr. Edwards, how long does the virus live on clothing? This is a question from a participant.
Clothing off the top of my head. I don't want to. Off the top of my head, I have surfaces. So in other words, in terms of metal, plastic, in our weather, probably about 3 days or so. Clothing and stuff is less, you know what I mean? But I wouldn't want to tell you an exact number because it's not in my head. But I would say definitely less than kind of 3-4 days, that kind of thing, And certainly,
yeah. Look, I'm running out of clothing. I mean, every time.
No, but clothing is simple. Clothing is simple. What we do know is that the evidence is that if you get temperatures up to about 50 degrees, 56 degrees Celsius, you know what I mean? At those temperatures, 10-15 minutes will kill coronavirus. So that if you're worried about your clothes, then you just wash them in hot water. It's really as simple as that. Right? It doesn't have to be boiling hot water, which is 100 degrees Celsius.
Yeah, but 10-15 minutes.
At 56 degrees Celsius, that's enough. You know what I mean? And then if you're washing clothes using bleach, right?
Mm-hmm. Yes.
So,
yeah.
There you are. So in other words, washing your clothes in warm water. You know what I mean? That's fine. I mean, a lot of people, nowadays, when they go, in fact, doctors working at hospitals, you will go to work, you know what I mean? And you hear stories of people, they get home, they stop at their door, they take off all their clothes, you know what I mean? Put it into a bag, and then they go into the house. And that goes, and they wash it right away, you know what I mean? So that certainly on clothes, less than 3 to 4 days. And, if you're washing them in hot water with soap or bleach, then, they're clean right after that.
Okay, so it seems as though certain temperatures, as you mentioned, will kill the virus.
Yes, no. So in other words, the higher the temperature in the environment, the shorter is the life of the virus,
Okay. So why are we concerned then? So why is there seems to be a general concern that in the summer, it's we're likely to see an increase?
Well, not theory. Well, let me back up a little bit. So it's actually the reverse. It has been theorized, you know what I mean, that when the summer months come around, we should see less cases as a general rule. And the reasons for that is that it's a general pattern of viral respiratory tract infections. So in temperate climates, what we tend to find is that we tend to see most viral lung infections in the winter months, you know what I mean, fall going into winter. And then when spring and summer comes around, the numbers fall. And in terms of why that is, it may be that it might be a question of the temperature and environment, but it is also the fact that in colder temperatures, people are more likely to, be close to each other. They're staying indoors, you know what I mean, that kind of thing. What we don't know is whether this coronavirus will behave like the other respiratory tract viruses, right? The other thing to say is that right now in the Caribbean, in Africa, in Southeast Asia, in India, in Pakistan, in the Middle East, they're all having outbreaks of coronavirus. So although it is true to say that outside, let's put it this way, the higher the temperatures, the less time the virus survives on surfaces, but it does not appear to be enough to prevent the spread of coronavirus around the world. Oh, Michael, I'm not hearing you.
Dr. Madhu?
Yes.
What is the situation on the continent in Africa? We're not hearing too many reports from that side. Can you give us a sense of what is happening there? I mean, is there a cause for concern that side or what? I mean, this is slightly slight diversion, but I know that you know, something must be happening there.
Yeah. So interestingly, you know, Paul and I, with a few other colleagues, just finished a major manuscript on, you know, COVID-19 in Africa, which is under review, you know, currently. So one, Africa is not monolithic. You know, the different countries in Africa, is about 54 countries in Africa. So they have different levels of sophistication in terms of health systems and healthcare infrastructure. Climatically, they're also not monolithic. You know, there are more temperate zones in Africa, more tropical zones in Africa. And so there are challenges that are not always exactly uniform. But let's focus this content on sub-Saharan Africa, for example, that appear on the same tropical zone, and probably most of them have about the same type of weakness in healthcare systems and infrastructure. We know that the virus is there. We don't know the rapidity of the spread, whether it mirrors what we're seeing in the Western world. But what we do know is that the time, the entrance of the virus appears to have been a little bit slower because of the different levels of intercontinental travel within Africa and the rest of the global community. But we do know that it's rising, and in some places it's more exponential than others. We do know that testing, you know, is not enough. Nigeria, for example, has recently reached 1,500 tests per day, and they have reported somewhere about 1,300 cases. But that, again, if you look at the exponential rise, you know, on March 8th, Nigeria had only 2 cases reported. So now they have about 1,500 cases. There's all this, as Dr. Edwards said, you know, we do know that the virus don't tend to do as well in hot temperature. And so no one knows exactly whether the temperature changes, you know, the temperature in sub-Saharan Africa may be a limitation. But we also do know that there are specific challenges because there is a lot of crowding in big cities. You know, Lagos has 20 million people. There is a lot of people that are in the informal sector. In most countries in Africa, about 50% of the population are engaged in micro enterprises that require, you know, social contact to do their trade. So it is also impossible to ask those people to stay at home for prolonged periods of time when the countries do not have social safety nets. Like the United States is sending out checks of $1,200 each to people below a certain income bracket. Countries in Africa don't have the capacity to do that. And 2 last things I mentioned that complicate the scenario in Africa, you also have to look at social cultural issues and religious issues, right? You know, Nigeria, for example, is about 50% Muslim and about 50% Christian. The Christian community is largely Pentecostal movement that is on the rise, and many of the pastors preach miracles, and then people look for miraculous cures, and so less likely to follow public health advice. And then the Muslim communities have, you know, admonition about alcohol. So many of the adherents are reluctant to use alcohol-based hand lotions or hand solutions. So that could be a complication in itself. Then if you take that, this cultural and religious aspect of it, and then you come back and look in the same populations again, and then say, okay, what about the infrastructure? Power supply is weak, water supply is weak. So the things that we need to stop the spread of this virus, social distancing, you can't really readily enforce because people have, professions that feed their families that require social contact. The next one is that you can't lock them down because they don't have the ability to support themselves, and then they don't have no power supply to preserve food supplies, and then you have water supply issues that create a problem. So we are just unsure what the pandemic will do if it takes hold in Africa. Right this moment, no one knows exactly the trajectory it will take.
That's quite an interesting background you just painted there. It's let me just kind of bring us back here a little bit. Does saline or salt water protect against COVID?
No, no. As simple as that. It's just like asking, does water protect against COVID? The addition of salt doesn't do anything to help in that regard.
Okay, so that we can throw that one out right away.
Right. In other words, bathing in the sea or gargling with salt water is not going to help either protect or treat against COVID infections.
Yeah, we're going to be. Can you? Another question again online here. Can one catch the coronavirus from urine or feces?
So we're waiting. There is some evidence to suggest that there is some, you can find virus particles in feces and in feces definitely. I believe in urine as well, but feces definitely. And there is a question as to whether or not that plays any role in the spread. So that for that reason, when we are taking care of patients with COVID infections, we're trying to avoid contact with all body fluids. Right now, we're pretty sure that most of the infection is spread by droplets coming from coughing and sneezing, you know what I mean, or contact with surfaces on which the virus is. But it is possible that contact with feces may spread COVID infection. We don't have that evidence yet, but right now we're treating all body fluids as potentially problematic.
Michael is off.
Oh, Mike.
There's some question. Thank you. There's some question around wearing a mask. Some folks say, I've heard some folks say, yes, it does, because, and some folks say, no, it doesn't. The thinking is that it's not an airborne, it's airborne, but not for long. It tends to settle on surfaces quickly. So therefore, the thinking is that if you're not necessarily in close contact with people, then a mask is not necessary. However, we have been told that, on the other hand, that look, wear a mask. What's the, what's the verdict as far as you're concerned?
Well, you're gonna break it into two. So the first question is mask. So the purpose of the mask is kind of on several levels. There are masks that we call N95 masks, which basically are very, very good at filtering very small particles from the air. And those masks will actually stop you from breathing in virus particles, okay? So the difficulty though is that those masks are very, very hard to find. And what we're trying to do is we're trying to reserve those masks for people who are in direct contact taking care of patients with COVID infections. And those are doctors and nurses and people cleaning hospital rooms and things like that. The other masks, so if you talk about your surgical masks, which offer some protection, they probably stop about 70% of virus particles, and cloth masks, which probably stop, as I guesstimate, probably 25, 30%, those don't offer great protection for yourself. But what they do is that if you have a COVID infection, asymptomatic or symptomatic, and you cough, it actually helps prevent droplets from going out into the air. So what we're telling people nowadays is that we want everybody who is not in their house to wear a mask outside when they come in contact with people. And what you're doing there is that you're limiting the spread. If you have a COVID infection and you cough, then what you're doing is you're reducing the likelihood that somebody else will get a COVID infection, okay? So that the putting on the mask in and of itself does not do a wonderful job at preventing from breathing in virus particles. It does help, but if everybody wears a mask, then what we're doing is we're cutting down the transmission of the COVID infection. The second issue asks is about how long does the virus stay in the air, and that is a complicated one, all right? It does appear that there are certain conditions, certain circumstances in which virus particles can stay in the air for a prolonged period of time. You know what I mean? Hour, 2 hours, 3 hours, that kind of thing. In air conditioning environments, it's certainly.
And this is with, excuse me, and this is with COVID?
With COVID, right, with COVID. In air conditioning environments, you know what I mean? There are issues in terms of virus being recirculated over and over and over again, you know what I mean? And so it's one of the reasons that we say to you that, if you're going to be in contact in areas where you're contacting people, even though you're not 2 meters away, you know what I mean, then you really should wear a mask, you know what I mean? The virus particles can hang in the air for a while. They don't automatically fall. The heavy droplets do fall to the ground very quickly, but you can have, relatively small particles kind of floating around for a while in the area.
Okay. Dr. Madhu, how do I know if the difference between COVID-19 and a case of the common cold?
Well, that's when it becomes a little bit tricky because you don't, unless you get tested. That will be when you have somebody who has symptoms suspicious for COVID-19, and that leads to testing for COVID-19 to find out if it's COVID-19 or something else. And in some places, they do what is a diagnosis of exclusion, where they test for things like influenza virus, the common cold, so to say. And if they don't have it, they can make a presumptive diagnosis that is something else. You asked a question a few minutes ago about Africa and COVID. That's also another very complicating scenario in Africa, because there are so many febrile illnesses that are endemic to the continent that will present in similar fashion as what we now know to be COVID-19. Malaria, for example, is very endemic in most countries in Africa, and then high fever is a common symptom of malaria. So most people will have fever and make a decision that is malaria between them and their doctors, and they get treated empirically, for malaria. But now with this COVID-19 complication, it's very difficult to tell without testing specifically for COVID-19.
Are emergency responders changing, changing their approach to persons with COVID-19?
What was the question?
Are the people on the front line, or the cardiologists, etc. People on the front line in general, but let's speak in terms of cardiology. Is there a change in the way the patients are approached in this pandemic?
Well, what we have long recommended is, pandemic or no pandemic, to use what we call universal precautions, right? If you assume that everyone has COVID-19, if you assume that everyone has HIV infection, and then, because everything boils to universal precaution. If you have universal precautions, then it should not change the way you take care of any individual patient, right? Because even though we say that these are the presumed symptoms of COVID-19, understand again that 20% of people are asymptomatic carriers. They have COVID-19, but do not show any symptoms. So if you don't use universal precautions, then you can still put yourself at risk, because the person you assume does not have it could be the person that will pass the infection over to you.
Let me go. Paul?
Sure.
Are the symptoms of COVID-19 different in children than in adults?
Yeah, yes. It does appear that children tend to have symptoms that are a lot milder. You know what I mean? They appear to be less likely to be coughing. They appear to be less likely to have high fevers. They also appear to be a little bit more likely to have skin manifestations, you know? So that generally speaking, less fever, less coughing, more skin manifestations, and generally speaking, more likely to have no symptoms. And if they do have any symptoms, have very, very mild symptoms.
One of the things that I hear, somebody was asking, well, just before I lose the train, I want to get back to Dr. Madhu for a while. Somebody was asking about mouth-to-mouth resuscitation, but is that done under any circumstances?
Well, I mean, it's actually a deeper question than that, because, you know, if you ask the question, should you do mouth-to-mouth resuscitation on somebody you don't know, you got to remember that you're putting yourself at risk not only for COVID, but for hepatitis, HIV. You know, there are a lot of diseases that can be passed by mouth-to-mouth resuscitation. So that it really does depend on the person who, you know, is going to be doing the resuscitation. I mean, do they want to put themselves at risk for that, you know? And the recommendation of the American Heart Association is that, you know, that has to be an individual decision. You really have to decide if you want to put yourself at that kind of risk.
What about, as a follow-up, since we're in that area, respiratory area, someone with a respiratory infection who has recovered from COVID-19, how long should they wear a mask after recovery?
That, yes, theoretically, what a lot of hospitals are doing is that you're tested twice. You usually have 2 negative tests prior to discharge, usually, you know what I mean? And theoretically, you should not be infected. You should not have the ability to infect somebody having left the hospital, you know what I mean? So that you could argue that somebody who has had COVID infection, has left the hospital with 2 negative tests, you know, probably does not need to wear a mask, because they would be unable to pass it on, and hopefully unable to get it. But that would be something to say, because what we don't know right now is how long the immunity, generally speaking, when you get a viral infection, you're immune. There's a period of time where you shouldn't catch it again. What we don't know right now is how good is the immunity for COVID-19 infections and how long does it last for, you know what I mean? So that it's an area that we'd say you should be okay in terms of not spreading it. What is it like when you get it again? Probably low, but we don't have that data quite firmly yet.
And I think I'd like to just follow up on that question about infected persons and recovering. Can someone who, as you mentioned, been infected, develop antibodies, can they be reinfected?
We don't know. We assume that, like most coronavirus families, you have immunity for some period of time. For common cold coronaviruses, that may be a couple of months, you know what I mean? For other viral infections, that might be lifelong. What we don't know right now is, you know, how long lasting, how much is the immunity and how long lasting is the immunity from COVID infections. We assume that it probably is going to be in the order of months to years. We assume that, but we don't have the hard data to say definitively quite yet.
There was another question in terms of the. I think we had it last week, but I mean somebody's asking this the question again, and that is persons who, let's say, heart patients who maybe suspect they might have the virus, but they're afraid to visit a hospital because they're thinking that, or a heart patient without the COVID-19, but they're afraid to enter a hospital environment because they think they could contract the disease there. And I suppose you can only speak for HIC Heart Hospital, so maybe that would be, yeah, you know. What would you say to that patient?
Okay, so the simple um, the simple message to that patient is do not delay seeking attention, because heart disease, it's potentially catastrophic if you delay treatment, right? If you're having a heart attack and you do not seek immediate attention, you may not survive it. And if you survive it, you may have severe limitation in both your quality of life and your length of life, because the damage to your heart muscles might lead to severe ongoing heart failure that is going to limit your functional capacity and limit your length of life. So if you're having chest pain or shortness of breath or anything that you believe may be related to your heart, our recommendation is to seek immediate attention. Now, we do understand the concern that people have that going to a hospital might put them at risk for contracting COVID-19 infection. And that is not to be dismissed, right? That we recognize that potential risk is there. However, the option for that is if it's not an acute condition, there is an opportunity to get virtual consultation, or what we call telemedicine, to get what we call telemedicine consultation with your physician, to sort out the complaint and see what is going on. Specific to HIC, at the HIC Heart Hospital, we have a specialized cardiac emergency room that is designed for this purpose. It is an emergency room that is not designed to be crowded. We have a guaranteed 15 minutes time from registration to being seen by a doctor. So it's an emergency room that was designed to be a socially distant emergency room anyway. So, and we have deep cleaning methods. Our staff are, encouraged to have a mask on, and patients are encouraged to put on a mask entering the facility. They get sanitized coming into the facility. The likelihood of being exposed to COVID-19 at HIC emergency room is extremely low, and that is a very viable option for patients with concerns for cardiac issues.
I have one quick question before we wrap here, and that is there's something called CBC. It has to do with the blood. It's called CBC. I'm trying to remember what the it's an acronym.
Complete blood count, is that?
Complete, yes. A complete blood count, can it detect the presence of a virus?
No, it's not what we call specific. So that viral infections can lead, so generally speaking, an infection can lead to an elevation of what we call the white blood cell count, which are the cells in the blood that fight infection. Mm-hmm. But depending on the infection and the body's response to it, a white count can be high, it can be normal, it can be low. There are certain fractions of the white count that can be elevated or low. So it's not specific enough to diagnose, a viral infection in and of itself.
Okay. And listen, we're going to have to leave our discussion here for the time being, but I just wanted to say thank you both, Dr. Ernest Madu and Dr. Paul Edwards, for your, your invaluable contribution. I mean, it's, information, as I keep saying, is one of the best ways I know of dealing with fear. And so therefore, I'm sure you were able to alleviate a lot of fears from our participants. And we look forward to chatting with you again next week.
All right. Thank you.
Thank you very much.
Thank you very much. And I just want to say thank you also to all our participants for making the time to be with us. And also, I'd like to say a special thanks to Carrie Ann Edwards, our very silent producer in the background there, who was making sure that things, run on an even keel. Thank you very much, Carrie Ann. And of course, I will see you again next week when we'll have another interesting program when it comes to COVID-19 and the heart. And of course, this is coming to you from the HIC Heart Hospital. So be well, stay well, and just make sure you take good care of yourselves. I'm Michael Anthony Cuff. I thank you so much for watching.
Thank you.
Thank you.